So with this, I request our last speaker and my dear friend, Dr. Varsha, to present her talk on restrictive strabismus following adherence post traumatic post RD surgery. Dr. Varsha has done a MBBS MS from IGMC Nagpur. She was lecturer in Department of Ophthalmology GMC Nagpur for 6 long years. She has a special interest in squint, has participated in many squint surgical camps, conducted instruction courses on squint in AIOS, MOS, and Vidarbha Ophthalmic Society, and is an invited guest faculty in National Strabismological Society of India, MOS, and VOS. She was president of Ophthalmic Society of Nagpur, scientific committee member of VOS and MOS, and at present practicing at Netra Sanjeevani Eye Hospital and Squint Center, Nagpur. Dr. Varsha.
Thank you,
12
Dr. Bhave.
minutes, make it. Yeah.
Thank you, Dr. Bhave, for the opportunity and for the introduction. I'll be talking on the restrictive strabismus following adherence, post-trauma and post-RD surgery. As we all know, restrictive strabismus is a form of concomitant squint where there is limitation of movement out of proportion to primary position deviation, and it usually causes troublesome diplopia. It is very difficult to treat and cure completely. I'll be talking about the acquired cases of restrictive strabismus after orbital trauma and for fibrosis post RD surgery. So, in restrictive strabismus after orbital trauma, the signs and symptoms they vary widely. They may be very subtle to severe. They may present early or late. To us, the early presentation, the diagnosis is difficult due to the associated findings like black eye, orbital swelling, and there may be restriction of movement, not because of restriction but because of pain. Patient may not move his eyes. And the late presentation after edema subsides, the diagnosis at this stage is easy as proper clinical examination is possible. And the differentiation between restrictive and paratic strabismus is necessary at this stage, and the treatment varies. So, post-traumatic restrictive strabismus is caused due to direct muscle injury, which may be avulsion, rupture or laceration. There may be orbital fracture with muscle entrapment, and swelling and scarring around the globe may cause restriction of the muscles. I'll be dealing a case of each. So, in the evaluation of these cases, complete anterior and posterior eye examination is essential to rule out the associated penetrating injury, visual acuity, pupil reaction to rule out the traumatic optic neuropathy. Then we have to assess the degree of limitation of movements, muscle functions, and conditions of the surrounding tissues. Ductions and versions are very important. We have to look for primary and secondary deviations, diplopia chart, His chart, FDT to know the restriction, FGT to know the contractile power of the muscle, CT scan and dynamic MRIs are definitely helpful to confirm the diagnosis. While doing the routine cover test, one point one must remember in cases of restrictive strabismus that occlude the each eye long enough to take up the fixation, because patient may not want to move the eye due to pain and not only due to restriction, as I said, and there may be poor vision or field defect which may prevent the fixation. Then the saccadic velocity evaluation in restrictive strabismus eyes, it will make fast saccades up to the limit of restriction and then stops abruptly. In paratic strabismus, usually eye will move with subnormal or increased latency, so slow excursion, floating saccades. Force duction test already been discussed. It is important we ask the patient to look in the direction of restriction of the eye movement and we can feel the tuck and restriction. Then general principles of management of orbital trauma in cases of restrictive strabismus. After clinical examination, if the CT scan confirms the diagnosis and if there is intact or paratic or minor muscle injury, we can wait for 6 months and see for the spontaneous recovery. If there is fracture with entrapment, then surgery is indicated. Muscle is lacerated or avulsed, then we can do retrieval, can be tried by the conjunctival approach if it is located anteriorly, and by anterior medial orbitotomy if it is located deep in the orbit. Damaged muscles if not found, then later on we can think of muscle transposition to correct the strabismus. This is a typical case of orbital floor fracture where there is periorbital ecchymosis, restricted elevation, enophthalmos, and other features may be abnormal head posture, restricted depression along with elevation. There may be sometimes emphysema causing exophthalmos. Then the infraorbital nerve anesthesia may be there. Here's chart showing typical the restriction of muscle because of the inferior rectus entrapment in the orbital floor fracture. Then the confirmation of diagnosis is by the CT scan, which is the best method to locate the typical blowout fracture, where the orbital floor gives, you can see the orbital floor giving way to the orbital contents, fat, fascia, inferior rectus muscle prolapsing in the maxillary sinus. Sometimes the orbital margins may remain intact, and the floor fracture may be associated many times with the medial wall fracture in some cases. So, in cases of management of orbital fracture, general principle, after confirming diagnosis, timing of the surgery is important. Surgery can be delayed 2 to 3 weeks if the edema resolves, but should be as early as possible to have better effects. And it is indicated only if there is a large floor defect, enophthalmos, troublesome diplopia, and abnormal head posture. And that can be tackled by the subperiosteal approach. The muscle is freed and it is sealed with the supramid sheath, and we have to confirm that FDT is negative at the end of the surgery. So this is a first case I will be showing. The 20-year-old female with history of road traffic accident 1 month back and presented with diplopia and squint since then. Immediately post-trauma, she had lead edema, conjunctival congestion, painful eye movements, and diplopia. But the acute symptoms were relieved by antibiotics, but she was referred for persistent diplopia after 2 months. In the primary position, there is small exotropia of 8 to 10 PD, severe restriction of the medial rectus, you can see here. The eye is not moving beyond the midline, and rest ocular movements were full and painless. Horizontal diplopia in the maximum in the left gaze, and FDT was positive for MR. So this is a H chart, diplopia chart, and the CT fracture showing the fracture of the medial wall, and there is a avulsed medial rectus entrapment in the ethmoid sinus. So in this case, this indication for surgery were diplopia and strabismus. This was done by our oculoplasty friend at Nagpur, Dr. Changule, and he did transcaruncular approach to medial wall. Medial rectus was identified, released, and porous epithelial implant was placed, and post-FDT, post-operative FDT for medial rectus become negative, and she was relieved of diplopia and primary position strabismus. Patients with medial wall fractures may present with varying motility and with limitation of adduction and abduction both, and asymptomatic cases may be there in case of medial wall fracture. So, but most important thing, blowing of nose should be avoided in such cases to prevent the further डिटोरेशन.
राइट साइड में देखिए, राइट साइड में देखो, अब धीरे से लेफ्ट साइड में देखो, देखो पूरा लेफ्ट साइड में, फिर से राइट साइड में देखो, फिर से लेफ्ट साइड में देखो, अब ऊपर देखो, अब नीचे देखो, अब बंद करो आँख, अब खोलो.
Congestion, the movements were painful. And the post-op, same patient, thereafter correcting the movements recovered fully.
इकडे पहा पूर्ण.
There was no strabismus.
डावीकडे, उजवीकडे, उजवीकडे आता वर, खाली, वर, इथे पहा.
Primary position squint, small exotropia is also not there, and she was relieved of diplopia.
मुझे अभी राइट साइड में देखिए, राइट साइड में देखो, अब धीरे से लेफ्ट साइड.
So another case is she was a 18-year-old female with a history of road traffic accident 4 months back. She had lead edema, redness, painful movements at that time. Except for minor small squint, rest symptoms were relieved with the medical management, but the symptoms aggravated after 7-8 days and then gradually increased till for 2-3 months. There was no relief with antibiotic and anti-inflammatory drugs. So right eye was normal, left eye had lydema, conjunctival congestion, all restricted movements, and the eyeball was pushed supero-nasally, and FDT was not possible because everything was painful. But on uncovering the lid, she noticed vertical diplopia. So CT scan was advised, and she showed there was a fracture of the medial lateral wall of the orbit with displaced fragments, and there was presence of thick inflammatory tissue and well defined thick walled collection. Here you can see the thick walled collection antero-inferiorly here, and the whole globe was displaced superior nasally, compressing all the extraocular movements. So the diagnosis was query hematoma or query abscess, and there was associated depression of the floor of the orbit without any clear entrapment of the oblique herniation. And in this case, again, because there was large swelling on the maxillary area, also extending to maxillary area, opinion of ENT surgeon was taken, and under his guidance, the exploration and drainage of the organized hematoma, it was an organized hematoma, under GA it was done, and there was full recovery of eye movements after relieving the pressure on the lateral and inferior rectus, causing restriction, and there was no diplopia. So she was preoperative like this, and the third post-op day she was totally free of symptoms and improvement in the ocular movements. This was a third case, 20-year-old male presented with blunt trauma with a scleral tear at 6 o'clock position 3 months back, sutured that time elsewhere, and then he came with abnormal head posture and diplopia since then. As there was no relief in 3 months, he was referred. On examination, he had a face turn to left, chin depression, and on undoing the head posture, he showed lower lid ptosis, and the FDT there was small exotropia with left hypertropia, and FDT was positive for inferior rectus. There was crossed vertical diplopia, and there was small scar on the sclera at 6 o'clock position, and it showed left inferior rectus weakness. On MRI, there were no signs of fracture or muscle entrapment, but there were abnormal inferior rectus signals noted. Adjacent to the floor showed some inflammatory reaction, so it suggested query inferior rectus sheath adhesions to the floor of the orbit. So this is the scan showing the adhesions of inferior rectus ruptured, maybe ruptured inferior rectus sheath adhering to the floor of the orbit. So because video was long, I just took the photographs. This was after exposing the 6 o'clock area. There were a lot of congestion, scarring on opening the conjunctival flap. You can see so much adhesions, and there was a lot of bleeding, and then these few fibers of the inferior rectus were identified, which were hooked. Then I took the sutures and separated, and then this area was exposed, and I tried to look for the inferior rectus fibers. At the infero temporal quadrant, I could see some fibers of inferior rectus. They were meticulously separated, and then by meticulous dissection I could find whole of the inferior rectus muscle there, and then I sutured it along with the residual fibers to the original insertion, and the patient showed relief of the diplopia and abnormal head posture. So preoperatively, first op day, patient was comfortable, and then he was perfectly all right. So just few words, last two slides. Post RD surgery, the strabismus is noted in 50% of cases, but it resolves spontaneously and persists only in 3 to 5% of cases, and the multiple mechanisms are noted. It is because of mechanical related to scleral buccal or adhesions between muscle and sclera. There may be fat prolapse, globe distortion, or they may be effect on the muscle pulley. So this was a typical case, young adult with scleral buccal in the superonasal quadrant affecting under medial rectus, superior rectus, and lateral rectus muscle in the left eye, showing exotropia and hypotropia. FDT was positive for adduction and elevation, and I have not operated yet, but the treatment plan is adequate exposure of the conjunctiva, removal of the buccal, but it is not easy. There must be lot of adhesions, and separating the muscle must be difficulty. But one precaution one must take, that at the end of the surgery FDT should be negative. So to avoid this post-RD surgery strabismus, the meticulous and proper handling of muscle by retinal surgeon is important, and if retinal surgeon should do FDT at the end of the surgery to prevent the further adhesions. So to conclude, clinical spectrum of restrictive strabismus, post-globe trauma and post-RD surgery is very broad. Proper history, clinical examination and ocular motility assessment gives a lot of clues. FDT, timely CT and MRI aid in correct diagnosis, and it's a great challenge for strabismus surgeon to correct the HP and diplopia in such cases, as the results in such cases are unpredictable even after doing meticulous and fine surgery. Thank you.
Thank you, Varsha, for a wonderful talk and very nice set of cases depicting the restrictive strabismus. I just want to ask one thing, that after post-RD surgery, do you excise the buccal while doing a squint surgery, or what do you do to the buccal?
Most of the time we have to remove the buccal to relieve the adhesions and separate, and we have to be keep the patient on regular follow with the retinal surgeon, and few studies show that in most of the cases retina is usually stable and doesn't affect the retinal status after removing, but mostly removal of buccal is needed.
Okay. So because we do these surgeries many years after the RD surgery, and so I think probably removing the buccal and
Yes, it is very
keeping them under observation is a safe approach, because sometimes with the buccal it is difficult to free the muscle or operate the muscle. Suma?
I do not remove the buckle because I prefer it to ask the retina surgeon and then remove the buckle. Otherwise, tomorrow
Yeah,
they'll say-
definitely. Yeah.
So I do a hang bag. I think the hang bag is better so that you can,
Yes,
don't need to take a scleral bite. So you can do a hang bag like not a semi hang bag or a pure hang bag incision.
Yes, already
Recession,
retina
yeah.
is
So
thin.
you have the insertion. So you just take a bite at the insertion and then like an adjustable only you put the muscle behind on a hang bag. So that helps. You don't have to remove the buckle.
Yes.
We have still 5 minutes left. Any questions on the talks anyone wants to ask? Yes.
Not exactly restrict. So, have you come across any restrictive or any strabismus after AGV, glaucoma valve implants? Because I had recently 2 people operated with RD valves, and within a month of surgery, they had poor vision, of course, and they had initially exotropias only. But post the AGV, they started having vertical diplopia, large vertical diplopia, and the patient actually started complaining of double vision despite the poor vision. So that's when I evaluated, and I was thinking it's probably a Brown syndrome kind of restrictive strabismus. But to my surprise, I found that it was mimicking a superior. It was just like a superior oblique palsy. So have you come across, and what would be your strategies? Like the idea is to save the valve as much as possible because it's working very well. So I'm contemplating whether I should think of it like a paralytic strabismus and do an inferior oblique recession rather than going ahead and because then the valve is working well and patient is relieved of his the multiple medications that he's on.
See, now we rarely see buckles. In fact, now what we are seeing is the Adi valve. After that we are seeing the means more like a restrictive strabismus. Also, I have seen 2 cases where the eye is not being elevated. So you can go ahead and do an inferior oblique. I mean, I have given prisms till now because I didn't want to disturb the conjunctiva. So I have given prisms, but you can think of the muscle which you feel is the antagonist, or we can
Have you
release.
come across any paralytic? Like it's mimicking just like in 2 cases.
No, I have not come across paralytic. It is basically I've got a restrictive where the eye is in hypo. Yeah, in both the cases the eye is in hypo. I've kept them on prisms. One I think I have done an inferior rectus. So now that is the next challenge of the valves. The buckles have stopped.
Yes. And another thing that you're doing a hang back, but then I found that most of the times for the buckle, you can't even hook the muscle because
Yes.
there's
Yes,
so
very
much
tough.
of addition. And there's like a pseudo tendon hole over, and so
very
you have to
tough.
go do a 360-degree peritomy. And
So unless you remove the buccal, sometimes freeing of the muscle is not possible.
Yes.
Yeah, I don't know. Maybe I have few cases which I've done. Maybe the retinal surgeons were so good. I have been able to free. I don't know. Maybe because they have really kept the sheath of the muscle intact.
So like what I found is that if it's a vertical strabismus with restrictive, definitely you feel it, there is a restriction. The restriction may be very minimal, but definitely that if you think it's restrictive, it's better to remove the buckle. But suppose sometimes you have these decompensated phoreas going into tropias with exotropias where there's not much of restriction. Yes, I think then in those cases you can save the buckle and you can do any technique hang back or it works well. But if there is a definite restriction, good meticulous dissection and removing the adhesions helps and only recessing the muscle helps, no? You hardly have to do any
you can't resect.
any antagonistic strengthening because usually
Yes.
the recession alone helps.
Actually, what you're saying is right because see, the buckle thing was there long back.
Yeah,
I think
yeah.
also I have not come across in the last 7 years any.
These
any,
were older cases.
These are older cases. Yeah,
Yes.
what you can remove the buckle because older cases, yes. Now we'd hardly see anyone because most of them are vitrectomy.
I just want to ask Suma one question is how do you do an LR recession of 18 or 19 millimeters? Because even sometimes doing an 8-9 millimeter recession is a challenge.
Yeah. So what I do is that it's a hemi or a semi. It's a semi hangback, no?
Hangback.
So basically, I would take a bite at 9 millimeter in
Okay.
between. That
Yes.
I'll take a bite at 9 millimeter.
Hemi hangback.
Hemi hangback, and then I will push the 9 millimeter behind.
Okay.
But yes, 18 millimeter, I will measure it. But where the muscle goes and sticks, I don't
Yes,
know.
because-
But I have not yet found that the effect has come. But so maybe it has gone and stuck at 12 or 13, I don't know.
Yes.
But definitely I do a hemi hang bite. Otherwise, it's not possible to do a normal scleral bite. Even 12 and 13 is difficult because there you have the inferior oblique.
Yes.
So always, most of the time, then your bite goes to the inferior oblique, so you don't want that. So 9, you take it at 9 or 10, where 10 millimeter is where your inferior oblique comes.
Yes.
So just slightly above it or slightly behind it, you can take the bite.
Okay.
And then you take again in the insertion because you're not taking a proper bite, so like a hemi hang back.
Yes. Okay, so that was one thing I wanted to get it cleared. Any other questions anyone is having?
Periosteal, I've not actually done a periosteal fixation for the scare that won't the patients be losing their field. So with the concern, because most of the patients have good vision in DRS. So when you're doing that, what's your the take on
I
that?
have not done periosteal
But then
fixation
I
for
think
DRS.
I think we it is advised and people have got good results. It can be then combined with SRT for improving the abduction. Slightly, no? What do you think?
I don't know. I have not been convinced that lateral periosteal fixation is
that's
good
what
for
I'm also not
DRS.
very convinced.
For a the synergistic divergence also, there's one eye which I have done because Dr. Pradeep Sharma said so. I have done in one case. It has worked well, but not for. I would prefer to keep it only for third nerve palsy.
I've done it only in one case of very severe abnormal innervation of LR muscle. So the first I did a recession of that muscle, but still the upshoot and lid retraction did not go, and so then I had to again go back and do a periosteal fixation of.
So
And
large recession works in those cases, like you do 18, 19, or maybe what you're saying is right. You could create into a sixth nerve palsy. You can do like 18, 19, and then you do an
then
SRT.
do an SRT
Yeah,
for
that's what you can
improving
do
the
if there
abduction.
is